yeah, this is really a great pleasure to have with us Judy Gichoya, who is an associate professor at Emory University. I'm sure many of you are familiar with her work. I'm a big fan of her work, especially related to fairness and health equity. And Judy was telling me just before we joined that this is the first time she gives this talk. The title is From Prototype to Practice, Bridging the Medical AI Implementation Gap. What else can I add? Just to tell you that if you are interested in the topic of fairness and bias in the field of AI, of course, Judy has done a lot of work on this. In fact, this is how I got to know Judy the first time, a few years ago, when she published a paper on showing how AI can identify ethnicity, race from medical images, which was quite an important work. And then from then on, she's done quite a few works on health equity and AI, and then on AI deployment and so on. And this fits very well, of course, our webinar series, which is focused on trustworthy AI through this work that we've published this year, the Future AI guideline, which has received a lot of attention. Of course, fairness is one. In fact, it's the first principle. So I think it's really great for us to have Judy with us. This is our last talk of the year. So I think it's a great way to finish the year. Next. So Judy leads at Emory University a lab called Healthcare AI Innovation and Translational Informatics. Do you pronounce it HITI? How do you pronounce it, Judy?
HITI, we call it the
HITI.
HITI lab.
It's very nice. And we're going to listen today about the work that is closer to deployment, to clinical practice. Just to say on the next slide that after Judy's talk, we will have a session of Q&A. So if you have any questions, please put them in the chat. The talk will be approximately 30 minutes, and then we'll chat with Judy, ask her all sorts of questions. I think we'll stop here and just give the floor to Judy. Thank you, Judy, for accepting to speak to us today, and we will talk in half an hour.
Okay. Thank you. Hello, everyone. I hope you're all having a good Friday. Ours is very early Friday morning, but we're looking forward to the weekend. And, when Karim asked me, like, hey, you should speak about your work. And I said, I want to push myself. And so this is me pushing myself. That means it can also go not very well, but maybe just provide feedback. And usually if you've heard me speak, then you'll see that I try to contextualize the bigger picture, why this matters, and then come, and narrow down to, to saying, why should, what other works have been done there. So today is going to be a little different, which would be mainly talking about almost like a reflection for the last, so this is my 7th year as faculty, and it's also my first job at Emory, and just in, after sort of fellowship. And I'm just saying, why is it that every day I still come to work at Emory, I still practice as an interventional radiologist, and this week when I came to work, I turned off the AI system because it was so bothersome. And then I also know quite a lot of people who are doing the same. And then, I also just spend time not just in radiology, because my interest is around all just of medicine and how AI is used. I go out to, non-radiology society, and they're very enthusiastic. And, they're saying all these things that I'm feeling like it's causing moral injury, because I'm thinking, wow, we already know that doesn't work. And so why is it so difficult? Why is it that Emory only has 5 algorithms used, in radiology? Yet there are over 1,000 algorithms approved in the real world. So, I thought that I would sort of talk about sort of my reflections and why, and also, like I said, it's a look back. So how that has shaped how I'm thinking. I'll tell you sort of what has changed. And I hope that you can either learn something new or at least provide feedback about sort of how to move the needle a little closer between our interesting experiments to actually how AI is used. So here are my disclosures. Now, when I think about the AI lifecycle, still fundamentally, we've always talked about this, right? Data sets, and then how we build model, and then deployment. This, if you look through all the years, we've ended up talking about the same. And, if I was to jump straight to data sets, today we have quite a lot of data sets. Midrick is one project that I'm involved in. In the past, you really had to be in a hospital, and I'll tell you why. You still need to be affiliated with a healthcare sort of delivery system if you're trying to move to practice. And this also is going to require multiple people, not one person can do it. And, Midrick is one such project, and it's, collect a lot of data. Now you can see over 500,000 studies. So, it turns out that you don't maybe really need to spend as much time building your own data sets, and you can focus on the problem that needs to be done. And there are many other, there's the IDC Data Commons for Radiology, which has many, many data sets. Some people use TCIA. The Marciage in Duke also is releasing quite a lot of data sets. And we are even moving from unimodal data sets to multimodal data sets and even new forms of data sets. And I'll talk a little bit about that. But why is it still really challenging? So one of our core things at the lab is building data sets. And one of them is actually Embed. We have now Embed version 2. And this is our mammographic data set. And so it takes us around 3 years, and we have full-time staff, not a postdoc, not a PhD, someone who's a data scientist building a data set. And, and what it turns out is that we don't need, our main lesson that we've learned is that it's better to build data sets from clinical variables. In fact, if you had all the time in the world, it's better to build it from possible questions that you can do. And it's, for my very, very sort of junior students, what I do is that I try to say, hey, read about, let's do, is there a systematic review? Is there a scoping review that describes the topic? And, do a replication study. So try to pick something that was published and then just see, does it work on our data set? And that's a good way to kind of get to know around the space, because if you build from clinical variables like our breast data set, then and sometimes it's just that this patient had a mammogram. So you're not trying to say, oh, these are the images I have, and then going back to look for the clinical information. Is that what you can do is that you're going to probably split different cohorts. And for us, we have, like the Embed version 1 had 10 cohorts, and 2 cohorts are in the public domain where you can get them for research. And so we needed to make sure that every cohort is representative, so that it's not like the cohorts we are left with at Emory are the only ones with cancer versus no cancer. And so, and because you have to be careful that you're not making the class imbalance worse. And this also kind of happened with our chest X-ray data set that we had to redo again. And if you start to say, fine, the only part I need to know is if this patient had an image, and then go back to, your electronic medical records or wherever else you want to do and look for more data sets, I feel like that has been more robust in terms of building data sets, especially with a fairness lens to building them. And then come up with a structure for organization of the data set and documentation, and I'll show you some of the things that are there. Keep your data set as more granular as required. And I'll show you how we sort of assign labels towards this. And be careful, especially if you are a referral center. So for example, Emory, where you get patients who come for breast cancer treatment from other centers, because that can bring a big challenge around, patient, privacy, and because sometimes you find burnt-in data set. And so we start with that. We have all these columns that are just describing the data, so metadata columns, but then the last stop we do is pulling images. And honestly, now we are not even pulling all the images that we need. We just have a comprehensive sort of data set that's well described, and then when the images are required, then we query them. But the most important thing, and that may be very difficult if you're not the one building the data set, is to ask yourself, why was the patient imaged? And this is because your assumption for whatever task you want to do downstream is very important, and is dependent on the reason for acquiring an exam. Now, this varies around the world. For example, in Japan, when we read the papers, they say that, you know, as part of your annual examination, you do get a chest x-ray. So you can get chest x-rays in normal patients. And just because a study is normal does not always synonymously mean that the study is, you know, the patient is healthy. So I think sometimes we forget about that. And especially as we start to think about opportunistic screening and how we are, you know, developing new image-based biomarkers. So here's a paper that can show you sort of like this complexity. So this group, they looked at volumes. You know, the heart has 4 chambers, and they tried to get a new, you know, like what's the relationship between the left atrium and the right atrium, and the left ventricle and the right ventricle. And they started to use that to predict major cardiovascular events. And you can see from this Kaplan-Meier sort of curve that this group with a very high ratio of, you know, the right ventricle and the left ventricle has definitely higher occurrence of, you know, events. But for you to do this, the first question you have to ask, right? Because this is a useful biomarker. And essentially you're saying there are patients who are getting these images, and, you know, they are at a very high risk of heart failure. And even this risk is within 2 years, but they don't have that diagnosis yet. But you have to know that this is a healthy cohort. And for you to, if you're going to just say, I'm going to repeat this study in our patient cohort, anyone who's getting an echocardiogram or you know, a CT of the chest could have heart failure or heart disease. And so that's why you have to be very careful and ask yourself, are you doing this? And why do you think the patient got the imaging study? Here's another example. We're building multimodal data set and multimodal models, and especially in the era of opportunistic screening. And, you know, it's difficult for us to say, you know, here's a patient with a whole body study. Now, we know that some very rich people are getting whole body MRIs, but those are not in the public domain or even accessible to most of us to be able to do anything with those type of studies. And those, you know, they're just being done as a health span type of, you know, imaging. But if you look at patients who get like a CT, chest, abdomen, and pelvis, those patients are either in trauma or they have cancer. So if you're trying to say, here's a healthy biomarker, here's an aging biomarker, then you have to be extremely careful. And for radiology, just try to see, is this usually acquired in a screening or in a diagnostic sort of way? For example, mammograms can be screening. So those women, we assume, are healthy otherwise, or they do not know that they have the disease. And then you can base that in your prediction. So as you analyze, and if you think about our data sets, they don't tell us that context. Why was the study performed? They don't tell us whether it's an inpatient or an outpatient study, making it very, very difficult. And it's very challenging for us to collect prospective data sets unless they're in a clinical trial. And those clinical trials, yes, we can be sure that the patients are healthy, but they're challenging because they're so controlled, because the clinical trial has a very strict inclusion and exclusion criteria, which means that for us to move from prototype to, you know, to practice, we really have to, like, maybe it's not feasible for us to prospectively collect data, and we have to augment this space with real world monitoring. So here's an example around how we label our breast data set. We start off by identifying, but this is easy to do in mammograms, where we start off with symptomatic and asymptomatic patients, and they both enter. If you have a breast, you know, lump, then you enter diagnostic examination. And we know that the BI-RADS category, so radiology has been very generous in trying to give these categories. Please note that they're always changing. There's actually a BI-RADS that's coming. So this could break your model. And, you know, so screening exams can only have a BI-RADS 0 or BI-RADS 1 or two, because 0 then goes into the diagnostic pathway, and then some patients come back to screening, some patients end up getting a workup, and then they also still come back to screening. But some of these patients who have a high risk of breast cancer, then high suspicion, then they get a biopsy and are classified. And if you're benign, then you can come back to the regular screening, and you can also undergo resection. So allowing us to think about this, and then also, like, when was the last contact of the patient that we have, is super important for us, especially as we start to think, are you going to build a predictive or a diagnostic model? You can look at this paper that we looked at an AI system for DBT and sort of see how we came up with sort of even how will you exclude, the model. And you have to know that quite a lot of models that are built, for example, the AI triage, those are not supposed to be diagnostic models, but in the real world setting, they tend to be used together, which makes it very difficult in the analysis. So here you can see we were trying to figure out who has cancer, who has, like at the time of diagnosis, to do the evaluation of the model. And, we were able to find that, yeah, we can see that the model misses 45% of non-invasive cancers, which these tend to be early cancers, and where you can have a good outcome. But also it's a limitation of the modality itself, because digital tomosynthesis, which is the modality we're looking at, non-invasive cancers tended to correlate more with calcifications, and calcifications are very difficult to see on DBT images. So mapping out where your patients are, and this may never be very possible, especially if you're using a data set and I don't provide that information, is super important for us to be able to anticipate how these models are going to work. So if you have to build your own data set, then you're most likely going to do mix and match. So if Karim comes and says, Judy, I have this study, and I'll say, I have this 1,000 chest x-rays that pulled for something else, right? We don't build a whole data set. And I want to say that it doesn't mean the best way to build data set is to use it as you build it. So start off with, not having the perfect data set. And actually, there's no perfect data set. Even the embed data set, which is now version 2, includes digital tomosynthesis, has also pathology slides, and also has ultrasound and MRI. You have to use those data sets as you go along, but as you keep using them, the data set gets better. And so if you don't have that type of resource, then you're probably doing this mix and match. And what that means is that, you're picking a data set. For example, if you want to say COVID-19 or COVID positive or negative, you'll pick, for example, chest x-ray and say this was collected before COVID-19. And then I'm going to pick up all the papers that are saying, here is how COVID looks like. And then you're going to match those data sets, or you're going to pick a pediatric data set that was done before. And then we have a good data set that has good performance. But if you look at the models that are built on these data sets, then they tend to have a lot of shortcut learning, because the acquisition parameters of those data sets is so strong that, if you pick a data set from the ICU versus one that's not from the ICU, then the model is just going to just stop and just really not learn anything else. So be very careful about how you do this mix and matching. And I saw Amelia on, and she has done quite a lot of work in terms of thinking, about the lives of data sets. And, before actually, we started collaborating with her and Veronica, we built a lot of data sets, but I hadn't spent time studying data sets. And that's an area that is going to require quite a lot of work. And I want to use the next type of slide, because we are also changing how we studied the data sets. And this is even made possible in the era of foundation models, where you can extract embeddings from these data sets. And now all of a sudden you can start to look at the radiologist doesn't have to look at millions of studies. They can just look at big clusters and come up and say, oh, I see that this is the pattern that I'm seeing here. That's how we've been able to label our embed data set with the implants, which are, and start now to evaluate the models based on breast implants. And so this iterative nature of building data sets, using them, documenting it well, is going to be super important. And you have to think not just about the images, but also the labels and the metadata and licensing, especially if you're not building your own data sets. But if you are, it gives guidance, especially in how the data sets are going to be used. So if you, end up using public data sets, it's painful to do pre-processing, and I'll discuss some of the lessons that we've learned from this. Here is again Amelia's work, which looks at the ISIC data set. When you look at it on the website, it just has a total of 38 GB, but when you look at it at Kaggle, you have just different, actually 640 data sets at the time of May 2024. You know, some of them have different pre-processing, some have different annotations. And, you know, so this has quite a lot of impact on how we, how the model is going to work in the real world setting. And it's important because, like I mentioned, that you don't have one perfect data set. You keep, looking at, some people will improve. For example, these are the most common data sets for chest X-ray that you'll use. But some people will say, you know what, I'm going to pick this data set and have radiologists annotate the pneumothorax for that data set. I'm going to add a label. I'm going to make it easier and apply different pre-processing. And you can, while this project really, it's a shout out also for more people to consider data sets evaluation as a good area of research. You can kind of go in here and start to look at the sort of like the relationship. And I'll tell you that this is not easy. So we looked at sort of like the traceability of mammographic data sets. And we're just looking, in the past, most people would look at social demographic variables, like how much, where do people report, race information. We know that, for example, in Europe and some parts of Africa, you cannot really label people, and we know the reason for that. And so, but when you start to look at the traceability of these data sets and where they are, the reason for image acquisition, you'll find that quite most of them are not reported. And so, so this means that we, especially, I'll tell you as engineers, it's easy when you finally spent all the time to make your data set good. Then what you need to do is a good data set and the clinical problem, and you run the model. And it turns out to me that you need to really say what task and how the three guiding principles for our work now is: why was the image acquired? And then how would this application be deployed, right? So you're thinking downstream and then thinking a lot about cohort creation, even before you build any machine learning model. And I encourage you to start to think about that. And for people who have just this fascination around studying how the data sets are used, I think this is a really prime area that we don't study enough. And although even we've seen, for example, NeurIPS and other, even Mikai start to say, let's bring these data set challenges, it's still not enough for us to look at the content of the data sets themselves. And like I mentioned, we sort of, and I'll tell you, by the way, looking at this paper, it was so hard, and the work that was done even on embed, because it's so hard to get that information, was incorrect. And if it wasn't as part of the author team, we would never have fixed that. There's even a correction to the paper because someone else came and provided that, an updated information and made also a correction. And so there has to be sort of these data sets as living objects that evolve, and you have to be making sure that you're using the right snapshot and documenting what snapshot was used as you move forward. And we know that another way of living is who the researchers that are using the data sets, and also where the data are being collected. We see that in Latin America and Africa, that those data sets are still very limited when you look at this span between 2017 and 2023. So still new incentives. And I know some of us on the call are doing a lot of work in sort of this the global majority areas to make sure that there is quite a lot of representativeness. And what's important here is, like I always like to say, I'm Kenyan, and every time I go back home, by the time people get studies, the study is abnormal. People know that they have disease. And well, mainly here in the US where I practice, most of those studies tend to be normal, especially when you're in more referral hospitals, not the large academic referral medical centers where people are coming in because they're sick. So that class in distribution can really affect your downstream model performance. And so as I move on from sort of like this fascinating area of data sets that I've gotten to learn just by not just building, but getting also just different perspectives, and is an area that requires quite a lot of work. I want to just point to these two projects. One is the Standing Together guidelines around data sets. But, and it was interesting to go through the Delphi process of this, but most of the time we document data sets at the end, and I can tell you that this, and we have a lot of work to even just do the documentation of embed quite better. That this is actually work that we're starting to think about it. How do we structure, and what's at the image level, what's at the patient level, what's at the instance, the study level. Those are language that for radiology you have to understand because it has an impact on how, for example, you're predicting breast cancer, your finding could be just, if you're diagnosing it, it's at the image level, but if you're looking at risk, it's really at the study level. And so those type of like decisions have to be guided by your project selection, but also aided because of the data set selection. And also this work looking at these data sets and how to think about them as living objects. And obviously this requires a big community effort. So once you have your data, pre-processing is another base. So radiologists will like this type of image. I can make a decision. Here is, one that has too much, it's not good quality in terms of interpretation. And so most of the data sets tend to be in, JPEG or PNG format. And you look at these two images and they're originally, they're from the same data set. This is the same if you look at the CheckSpot data set, you can see that sort of the distribution of the pixels is very even, but on the SIM ACR dataset that there's quite a difference in processing. So it turns out that the DICOM standard, which is used for exchanging, it's a very strong and old standard and has quite a lot of roles to play. And if you're going to work in this space, especially, I encourage you to think about it, especially if you're going to say about the downstream task. And DICOM, the raw pixel data is stored in the DICOM file, and the DICOM standard provides instructions on how the images should be displayed. And this is, the LUT or windowing tasks. And those can play a big role in the pre-processing. And we shared this, and we share the code of even how to use it for test x-rays. And we show that you can have higher performance and higher generalizability. And when you don't have DICOM tags, so most of us may end up using histogram equalization or CLAHI. It turns out that you can see this is the LUT image here. You just trust me that this is very understandable to a radiologist. You can see sort of how this was the original image, and sigmoid based processing comes second to thinking about the LUT processing. And this is not just a problem for traditional deep learning. When you think about foundation models, and we just looked at this this work as this was actually in the supplement as we were looking at the quality of embeddings from when you have a long tail class, right? So the foundation models don't really see any radiographs. Should you use it or should you use deep learning approaches was pretty much the question we were answering here. And when we say, is this a knee radiograph? The top row, A, the model starts to say, no, I don't think this is a knee radiograph. And this is, you can clearly see these are knee radiographs, but it's really an impact of pre-processing that is making the model fail because they have low quality and high noise. And so, and by the way, one comment about foundation models is that everyone puts their pre-processing pipeline, which even makes it more difficult. So you have to think about labels, and we've talked about different lives of labels. The radiologist, and also pathology, you always have your medical image and then the associated report. It has different sections. It has the study name. It has the indication, which is the reason for the study. Why was the patient image? If there are prior images, and then it has findings and the impression section. So some of us will look at the impression only, others will look at the findings. We always, for example, chest x-rays, we've always used CheckSpot labeler. And we know that there's quite a lot of variation. For example, when there's uncertainty, where there's also, for example, when you say like there's no sign of focal consolidation, effusion on pneumothorax, which for radiologists, we know we're just saying all those things are not missing, but for NLP models, sometimes they can struggle with that. And so, but when we think about sort of like the impact of labels. I think this is an area also of just interesting work, you know, and you're starting to think about the subgroups that I kind of showed, what's the quality control that is necessary for this labeling. And most of us have moved on to using LLMs for labeling. And, you know, the decision for the large language model labels is because that, you know, first of all, they do work better, as we show in this case. So here is a human performance. You can see different multiple open source models, and we're looking at the human performance, who in this case is the gold standard. So why does this matter? For RSNA to run a challenge, they have to get radiologists to label their data sets. It's very, very expensive to do that. And if you could figure out that the performance of the human labeled data matches the LLM, then you could just maybe focus on the human labeling the test data set. And that sort of moves the needle more towards more generalizability. And we find that, you know, LLM models definitely work, LLM-derived labels work better than the Textpart labeler. And what's interesting is that there's not one size that fits all. And we've worked out quite a bit on this. Number one, if you have subgroups, then these subgroups, the models don't do well with them. And, you know, obviously larger models tend to show much better performance. And we know that especially for the commercial models, that their versioning keeps changing, and you may not even have access to an older version. So you have to be very judicious about how you store your information and your versioning and good development practices. But what was interesting for us is that the chain of thought prompting, and especially as we've moved to more reasoning models, right, that try to give you an explanation of what they're thinking, we found that those decrease the overall performance. And this aligned quite a lot of it with papers that had started to show that overthinking, and I'm using those words loosely because they're sort of like they're commonly used, but I don't really believe that the LLMs think, because this negatively impacts the model performance on simple tasks. So I still think we need more domain-specific labeling, and in our work for quite a lot of labels, we found that they're not sufficient. They're good enough for binary, they're better than what we're using, but they're still not enough for, especially when it comes to real-world performance. Now, we know that label noise, during model training, the label noise is actually well tolerated. But when it comes to AI evaluation, here is where it gets interesting. So you have your radiology report and you have your image, you extract your reports using labels using LLM, and your model, you know, has its performance. And it turns out that for AI evaluation, the label noise actually should not be tolerated. You should almost look for a perfect model. And it's actually affected by the disease prevalence, and you need to report your best case and worst case scenario. I'm going to guide you to look up this paper that's just about to, it's undergone peer review now. And here you can look at both directions, that if your model sensitivity is 0.9 and your model specificity is 0.92 and your LLM specificity is 0.95, and your population has a prevalence disease of 10%, then your best and worst case scenario is that you're going to be reporting that your model sensitivity, that you're going, you know, the model's true performance really could be between 60 to 96%. That's a big range for me to decide, should I deploy that model or not? And so it turns out that when you have low prevalence disease, you should really move your LLM labeling, especially for the specificity, as high as you can. And so this paradigm shift, that the labels and the data sets that you use and how they're going to be used downstream, are you going to be evaluating or training, really has been, it's so simple when I say it loudly, but was just something that I didn't really think about as we started off. Now, we know that we have, and we are at the 30 mark, but I'm about to sort of come here on the home stretch. You know, there's the concept of model as a data set. And I describe this because we can have synthetic data. We know that this overcome, for example, data sharing. And I maybe 2 years ago, I was not a believer in the role of synthetic data. And then and we've actually finished a paper that describes sort of like what are the possible things that can be done with synthetic data, for example, education, augmenting rare disease data sets, improving thinking about privacy. And I want to show you sort of like some of what we know, how does synthetic data help moving from prototype to bedside. And it turns out that if you had good trained data data, especially synthetic data, especially because with the conditioning, we know that you can say, just learn this characteristic of the data. Then you can improve the model performance and on both internal and external testing. So here is just the real data set on TechSpot for, just prediction. And you can see that when you have 200 to 300 times of the original test data, then you start to bypass the, sort of like the baseline model. It's not, a replacement of real data, especially when you have a change in distribution, because they seem to still struggle with the same. And then we also worked on looking at this synthetic data for data-centric training. And this work is under review, where you say, maybe if you have good, well-trained, conditioned data, that you could use it instead of this paradigm of pre-training or post-training, and use it to make sure that you're training fast before you bring the real data, and we show that it's more generalizable, narrows the disparity gaps, and we still observe better performance for this type of model. So we know that right now, your architecture, you're going to choose many things. You can use a rule-based system, probably not anymore. You can use sort of like classical machine learning, the XGBoost, although they are back now with the foundation models. You can use a deep learning approach, or you can use a generative AI. And even now, everyone wants an agent that is going to interpret your result. What we know today is that AI is a strong feature extractor. Here, we did some work that looked at prediction of diabetes. And this is before foundation models, where you could extract conditions. And I don't think I really appreciated the significance of this work till now in the era of foundation model. This is a very simple model. You give a test X-ray. Instead of saying predict diabetes, you just extract all the features, and then you train a model downstream that says, hey, here are all the features, now predict whatever task you want. And you can see these predictions. And we showed that this model actually could predict who has diabetes pretty well. And it could even say who had control or uncontrolled diabetes. And this to me is synonymous to what we're seeing with the foundation models. But what we're seeing is that age, not even race or other information, age tends to be such a strong encoder for underdiagnosis. And this is because most of these type of things, for example, a pacemaker device, tend to be in older patients. And that's all the model is picking up on the features. And we know that the image component is not that strong. And this paper, and this paper is already reviewed, but I like the preprint one because I thought it was very interesting, where they provide misleading labels and they see what the model performs. And when it has a correct label, now, granted, these were not pathology-specific models, but the model performed very well. But when you remove the label, the model started to just really struggle with this prediction. And then on the other hand is that the models also, when you say ignore the text, which is what everyone is trying to tell us, that we can, ignore the text and do all those things, it turns out that that doesn't work. And so as you start to think about your task selection in this era of where we're bringing more complexity, and it's very powerful because for the same model, you can either do a classification task, a regression task, or a survival task. For example, trying to determine if you have good cohort creation. But we don't know, we see variable performance that when you have a model that you just wanted to interact with the doctor, then you want to be able to say, hey, maybe you need some language component in it. But when you want a model that is doing segmentation, that we find that this all this complexity, that it's not as robust, and we still struggle with the same problems of LLMs with hallucinations. And we also don't know how to evaluate better when you're not just predicting here's the abnormality and you're giving the radiologist report and what that looks like in terms of the workflow. So finally, I want to talk about and just highlight this, that it's not just the data set and the model and the architectures that are necessary, but also the human factors. So most of the time we've looked at AI evaluations as pre and post. This is our evaluation looking at the radiology residents, and we see sort of like the time savings. And it's interesting because when there is a positive finding, we find that, sort of like there's actually variation versus the negative finding. So the junior residents are not very confident. And this is changing paradigm of how we train our doctors. We find that they quite get a lot of time savings, especially for the junior trainees. But overall, when you look at time savings, it's in terms of of seconds. And so we need new metrics that align us better to think about how can you how can you really evaluate the value of AI to the radiologist? And that's why you're not going to go to work every morning and just turn it off. And so as we think about real world monitoring, you can do it simply like this team here that picked up 50 patients and showed that when they flip the images, that the commercially approved model doesn't do well. Here's like a more sort of how we are doing it more thoroughly, going through the whole pipeline, but again in an iterative cycle. This is monitoring of an IC intracranial hemorrhage triage model. You can see sort of all these labels that we're starting to come up with in terms of evaluation. And in our evaluation, we found that the model works best for patients who have acute hemorrhage, who have multiple compartments, and who have large hemorrhage. And so when you look at where the acute hemorrhage versus non-acute hemorrhage, we find quite a lot of differences in terms of those labels. And so when it comes, and this is why the complexity of thinking about value and evaluation in the real world setting, finally we observed that our model actually had worse performance for Black patients and those who are under 40 years. And it turns out that our Black patients come through the emergency room and outpatients. And I didn't spend too much time here, but I would have shown you that the location here matters a lot in terms of where the model performs. So we knew that there was already a 10 performance drop for these patients, but these are the patients who need better triage because they are going home. And so if you're in the hospital, you hope that there's someone else who's going to realize something is going wrong. And then when you look at our age clusters, we observe that our young patients are Black and our older patients are white. And so it's sort of this intersectionality of our identities and why one label cannot be sufficient and not just the social demographic labels. And then our further characteristic was that our Black patients had subacute hemorrhage. I already said that the model works well for acute hemorrhage, and white patients had acute hemorrhage. So this could be a factor of delays in access. It could also be a marker of not being believed, and we don't know that. So those are clinical non-AI things that we're looking at, which is why it's amazing to do AI in a sort of a healthcare provision system. And Black patients had single compartment hemorrhage, while white patients had multi-compartment hemorrhage, which we know our AI model works better for. And this could be because of the mechanism. Hypertensive disease tends to be more common in Black patients, and that presents with single compartments hemorrhage, while surgery then will result in multi-compartment hemorrhage. And so this is impossible for anyone to do in the FDA or wherever agency that they can do this type of evaluation, which makes me tell you that AI is going to be local, and we have to have really thoughtful collaborations to bring it meaningfully to the bedside. I want to end with these resources. We do a lot of data sets. Most of the stuff that I've said, it's either on this documentation page. You can just go there and read and provide feedback also. And every year we organize a datathon, which also starts with the summer school that we discuss sort of like some of the things that we are learning and sort of how that is changing how we build AI systems. So thanks again. Here's a snapshot of part of our team here in Atlanta. If you're ever around in Atlanta, please let us know. We'd be happy to host you. And here's my contact information. Thank you.
Thank you so much, Judy. It was great. You've showed us quite a few angles, quite a few work that you guys have been doing. All very interesting, all very relevant. And now we'll spend the rest of the time until 4 p.m. here to ask you a few questions. I've got already some questions here that were sent to us. I would start with this one. So a lot of what you presented today, how does it apply specifically to low resource settings? Are there unique problems that need to be taken into account when adopting AI in real world practice in low resource settings?
Yeah, and I actually, believe it or not, I have a big slide deck about this because I spent some time I spent still quite a lot of time in back home in East Africa, and earlier this year I spent some time in South Africa at University of Pretoria. And so I think first there's a society impact, and this is because most people are, first of all, there's this fear that we are being left behind. So quite a lot of people are saying, there's a government thing that is saying, look, you need consent to build AI. So there's that sort of the practical enabling environment for us to build AI. Now, today with the embeddings, especially from foundation models, it turns out that you don't need very big data sets to build a downstream task or, adopt it for your task. And so I see that computation hurdles can be avoided, in my opinion, for deployment. The challenge is that the infrastructure, and this is because most data sets are still deleted every 3 months. People are not storing data sets, and then there's quite a lot of opportunity for capacity building. And then other people who are going in, like companies or nonprofits, they just want to go in and just say, I'm going to, sell, the system. You probably don't have a PAC system, or people are saying that, oh, no one reads this X-ray, so I'm just going to sell you this AI system that's going to interpret the X-ray. So there won't be any infrastructure for quality monitoring. And I think that's, if you're going to take away anything from my talk, is that, like, when it comes to the width, AI is hard. But when you're not just building the model, to make it useful, it's hard. And if you don't have the infrastructure to be storing images, thinking about the quality control, then you're going to cause more harm using AI systems. And so to me, when I host people from back home or bring some capacity, I'm just saying prioritize the infrastructure, prioritize testing, like monitoring, and then evaluation, and putting a quality control system in place as a starting point.
Thank you, Judy. The next question is precisely about monitoring. So the question is, everyone understands the need to do monitoring, but somehow it's not common practice, huh? Why do you think that is? Why is it not common practice to do monitoring?
Yeah, so it's really difficult to do. I also used to think that it's easy, but as a group that's doing this, one is the infrastructure that's necessary. So you could have said, yeah, labels, like, to me, when you're building labels for training models, I can give Karim noisy labels. He's gonna get a great model out of it. But for monitoring, even for example, that label noise that I was showing you, that your specificity for your LLM, you have to think about the disease prevalence. Like, who knows about the disease prevalence of the population that you're studying? We don't know. And so there are all these things that, and everyone in the past would say, hey, here's the implementation science, you can adopt these principles. And I'm pushing back, which is sort of like why I try to make this talk this way, that I'm pushing back and saying, no, we need new styles of doing things and thinking about it for us to think about the AI evaluations. We don't have the already identified subgroups. Now, someone can pick the ones we've come up with for intracranial hemorrhage, but another disease will require new subgroups that no one is developing. So it's not as straightforward. I think when we started, I used to think it's easy, but when I started doing it, I was like, oh, there's quite a lot of work to be done. And even today, if I say the LLMs are not very good quality for real world monitoring at that level, they're good for training. I think most people wouldn't believe it, but we spent like almost 7 months just cleaning up labels for that intracranial hemorrhage detection.
That's very good. Thank you so much. The next question here I have is related to legal aspect. So it says, yeah, how could hospitals and healthcare centers, when we talk about AI deployment, evolve their highly outdated legal system to incorporate AI technology?
Yeah, so in healthcare, I don't actually, first of all, there's a geographic difference, right? So in the US, people get sued a lot. That is when you say legal is because of liability, right?
Right.
It's not really, there are some lawsuits like in other parts of the world, but not as intense as the US system. So that's variable. And then secondly, is that I think maybe regulatory system, especially this has become a big issue, especially with OpenAI and all these big companies building large language models. Are we relying on an outdated copyright, system? But I would say that the legal system in medicine is actually very forward thinking. There's a HIPAA law, there's incentives for sharing data, and if you think about Europe, the GDPR, I think initially thought to be more restrictive, maybe what ends up being protective, especially with how much theft, of resources and of data is undergoing to build even more models, And so I would say that I think medicine, we've always embraced sort of some form of ethics or, governance or legal. It's not robust, and it's mainly grown because of mistakes that have happened in the past, where doctors have caused quite a lot of harm. So I would say that there's quite a lot of innovation and the truth is there's no one single model, and we should move away from trying to build one single model. If we can move away from that, then you can focus on explainability, putting checks and balances that make sure that the human is not undergoing automation neglect or automation bias, and people can use more than one model, and maybe that's where these agents are going to work. But I think everyone is trying to build one model, and it's really, really difficult to do, and it's never going to work.
Very good. Okay, now I'm going to open the Q&A on the chat here. Yeah, I have here a very concrete question, specific question. I don't know if you could give advice regarding X-ray in particular in Africa. So I think this is related to a project that started recently in Africa called Africa HITI, and it's about doing federated learning in 10 sub-Saharan African country for chest X-ray and chest ultrasound. And this question is related to protocols. Is there any advice you would give on how to come up with protocols for X-ray and also ultrasound of chests in a way that it's easy to acquire perhaps, or easy to make standardized across all the different places in Africa?
So again, I would still say what the task is, right? So if it's just a pure academic exercise, then, yeah. But if you want
probably
to deploy,
clinical as well. We want something impact in the future.
Yeah. So then absolutely that you cannot standardize. What you have to do, there are a few things, and we went through this thought process. What you can do is make sure that you're storing all images, capturing them, putting them in the DICOM format. So that's pretty standard things. DICOM format, making sure that patients are linked to one patient, right? So you can start to figure out like if you have false positives or false negatives, right? So a registration system. So it's putting the infrastructure more than specifying how the images are acquired. For the specific images, you can build a simple like data, and we do this quite a lot for us for our own data sets, but here's a place where you can build a simple model running on the edge that's just a quality detector, right? So that if it's poor quality, you don't want to wait so much later to figure out, oh, you know what, this image was bad. When the patient is there, you can just repeat the image, right? So we've built some of this. For example, the model that I mentioned about breast implants, we've built something like that could hypothetically, instead of waiting, the patient now is non-diagnostic, to improve the quality of something like that. And you also see why that can be tied to training, because if you find that it's only Judy who's getting these bad images, then you can sort of also bring a component of training. So I would focus on really start using DICOM. Honestly, if you do that and then do some form of registration, and then if these images are being interpreted by someone else, because you're not going to be able to relabel them, and you also want to get the labels in the real world setting, try and capture that report in a specific form. So I would, if the places you don't have a dictation system, I would provide them one.
And do you believe in those simplified protocols? So, for example, in obstetric ultrasound, there are those simplified protocols, that perpendicular lines.
Yes.
Would you do the same for chest
like
X-ray?
For I think we haven't so there are some in the ICU, but they're very specific, right? Like heart failure, right? The Cali B lines. I think they haven't been standardized, and what you need to do, I think, is to figure out what's going to be your like your gold truth. But I think there's quite a big role, especially with what the Gates Foundation is doing, deploying all these ultrasounds without a specific protocol. So working on just the image acquisition, I think, especially for ultrasound, would be very interesting.
Okay, we still have a bit of time and quite a few more questions. The next one, I'll ask it my way. I think it's a question about data synthesis from 2D to 3D. I don't know. So, for example, for breast mammography, you could perhaps build such a system that would go from 2D to 3D, could be 3D MRI or something. Do you believe in this type of data synthesis?
Yeah, so so I think one area that's gaining a lot of interest is the digital twin, right? And so that's one form of using synthetic data to transform it to something else. I'll say that not for breast use case, there's already a good 3D. Actually, it's done the other way around. So there's a 3D image that's converted to 2D and saves acquisitions of the images. And so that is increasingly being applied to shorten the scan times. We know that this is being done even for MRIs, so that people can just require just a few scans and you have all the information. The place also where you're moving from modality to, right? So there's the conversion, but within the same modality, but where you're moving like from CT to MRI. I think we see quite a lot of work here with radonc, because they get during planning, when you're getting radiation, you're getting a study acquired every time, right? And so people are trying to reduce sort of like how many studies have to be acquired, and also adopt these dynamic imaging protocols that allow you to say, you know, my radiation plan should change because the tumor is changing. And so there's quite a lot of work that's being done on that, but not because, you know, like someone is going to say this 3D and it's going to miss to catch cancer. We know that that's not going to happen.
Last question before we go. Somebody is asking about label data, which are labeled mostly by specialists, but then sometimes you can have wrong labels. I think you mentioned noisy labels in your slides. So what do you suggest to tackle this? And he or she in the question mentioned using LLMs to get a kind of silver standard. What do you think of this approach?
Yeah, so multiple labeling approach. This is a painful lesson. We even use AI to label data sets. So if you have multiple good models, you can see where there's discordance. And the reason why this is even more important is that if you just rely on the report itself and not the image, if I missed it, my report is not going to capture what I missed. And so if you don't keep improving your label quality. So one chest X-ray for us can have almost 5 different extracted labels, and we just start to look at the consistency. We also use segmentation. So for example, cardiomegaly, we got checks mask to label the cardiothoracic ratio. Then we got an echocardiogram that said what was, you know, are the chambers enlarged? So we use multiple data sets that are close together, but also use other you know, not just one labeling strategy, you know, is the thing. Yeah.
Thank you so much, Judy. We arrive at the end of our session. Thank you for making the time for us. I know you're very, very busy. We're very glad to have had you for the last webinar of the year, and I hope we'll be in touch and collaborate, and that you'll collaborate with others who are on the line. I'm sure you'll receive some emails soon. Thank you again. Thank you to the audience, and we will continue with the webinars in 2026.
Happy Halloween.
Thank you so much. Happy Halloween, everyone. Goodbye. Bye, Judy. Goodbye.